Okay, so share is up here. And then choose your presentation. Yeah, and then they should only be able to see that.
Okay.
But why on this screen, why are we only seeing that?
Oh, I didn't start it. Slideshow from start. Do we have to record this? Are they all recorded?
Well, Will wanted me to record it.
Okay.
So if you wanted to, you could turn it off and just turn it on when he starts.
I don't really care either way. I don't think I can change it.
Yeah, because I told it to automatically record.
Okay. So that's
Okay.
going.
And your screen is shared, looks like, right?
I will see if I can log in from my phone and see what it looks like.
Oh, yeah. Good idea. I'll do it too. I don't have very many people that are tech savvy.
Okay, I see the presentation.
Okay, good. So you're good. What did you just use one of these things to plug in?
I tried that one and it didn't work, but I have one of my own.
Oh, okay, that's good.
I ordered cookies. I don't know where they are.
That's awesome. You need me to go down and pick them up for you?
No, I asked the IPS resident to.
Those big giant cookies?
Yeah, or insomnia cookies. I don't know.
Yeah, I had somebody else ordered those. It's like, oh my God, those are like to die for. I mean, they're so big.
I don't think I think those are crumble cookies. These are more normal size, I think.
Okay. Yeah, they were like that.
Yeah, I don't think they're that
like
big.
You like go into a sugar
Yeah.
if you have one. Okay, so you're good to go?
I think so.
Okay.
Oh, that's up
it looks
there.
Nice.
I totally underestimated the amount of time these take.
Did you?
Yeah, I should have asked for non-clinical day because it took me probably like 6-7 hours to put it all together.
Oh my goodness. Well, you can give it again next year and then you
Oh,
can
yeah.
go.
Yeah, I asked Will Chan for his slides. This is recording.
Is it? But is your sound turned off?
Here, I'll mute it.
I'll let.
All right. Hopefully, people who are.
Your butts in here.
If you guys can't hear me, I don't know how to fix it, so just deal with it.
Can you speak up, please?
Talking to Sajin and Pinky. All right. So obviously, there's a lot of chronic pain.
We can hear you fine.
This is my first time giving any lecture to you guys, let alone this lecture. It takes a lot longer to put these together than I thought. So, just stop me if you guys have any questions. This is, there's a lot of information here, but just stop me. I'm going to try to cover anything that I think would be high yield from all the ITEs and boards. All right, so these are some of the topics we'll do. So this always somehow ends up on the ITE. So your analgesic stepladder from the WHO. So again, this is all stuff we know, but your first step are non-opioids, your NSAIDs, Tylenol, then you move up to the weak opioids. So Tylenol 3, Norco, Tramadol, and then stronger opioids, and then eventually nerve blocks, epidurals, spinal cord stimulators, the kind of chronic pain stuff. So you escalate up, but you also need to escalate down, and we do a little bit better job of using multimodals. So we're using some of these other adjuncts, blocks, epidurals alongside of step 2 and 3 before we get to that point. All right, so the pain pathway, you don't need to know all the details of this, but you need to kind of be familiar with this. So noxious stimuli, you stub your toe. So the noxious stimuli stimulates the nociceptors in your little toe. That information gets propagated to the spinal cord through your afferent nerve, goes to the dorsal horn. It synapses there, and then you have a release of pain neurotransmitters. What are your major pain transmitters? Substance P and glutamate, yeah. So those synapse at the second order neurons in the dorsal horn, then crosses over at the spinal cord. It goes up to the brain via these second order neurons in the spinothalamic tract. And in the brain, the second order neurons release more transmitters to third order neurons in the thalamus. And those third order neurons, locate the pain to the somatosensory cortex. So there's two main different types of nociceptors. These are the afferent nerve fibers. You guys know what these are? The two major types? Just shout them out if you. All right, so it's the A delta fibers. Those are the myelinated ones for fast, well-localized pain. So that's that instant, like, okay, this really hurts, this is sharp pain. And then you have C fibers, which is smaller, they're unmyelinated, and that's for that like dull, achy, throbbing pain. All right, so we talked about glutamate, substance P. Those are the stimulating neuroreceptors. Do you know what the inhibiting neurotransmitters are? GABA, glycine. Yeah.
Sorry.
Oh, yeah. Get some cookies. All right. So, so this always ends up on your boards, like addiction versus dependence. So addiction has that pathological use. So you're doing disruptive behavior, negative behavior to achieve this appetite. You're preoccupied with this behavior, loss of control, negative side effects. Dependence is normal. Dependence is upregulation of receptors, and you can have a withdrawal when it's removed. So people who are on high dose beta blockers, your body upregulates the beta receptors. You have more, you basically get dependent on it. Same thing happens with opioids, but it's just important to differentiate between addiction and dependence. And this will somehow come up on, I think maybe you get one question every other ITE on something like this. So the first thing we'll talk about is cancer pain. So there's so many different types of mechanisms for cancer pain. So the big thing is, and again, this just doesn't apply to cancer pain, but any chronic pain, H&P, physical exam. So again, this is almost like internal medicine again. So get a really good history. Use opioids, adjuncts, and that will help with most of the pain you will treat. Goals, again, just like any other pain, improvement in functioning, better treatment compliance, and it does indirectly influence cancer survival. So you treat your patients, you treat their pain, they're more able to make it to chemo, make it to radiation, and so they actually take part of their treatment, they'll do better.
I think we got that question on IT, or at least it was like one of the 4 options.
Okay, yeah.
It was like, which of these is not? And I got it wrong, but that was an answer choice.
Okay, good. So at least one of my slides is good. So epidemiology, again, so cancer is so variable, and there's so many different types of cancer, so many different types of pain. So there's no standard studies. There's no gold standard method to assess pain. There's the VAS scale, but that's, I mean, we know how crappy that is. The other thing to realize is, so just because they have cancer pain doesn't mean they don't have pre-existing or another acute pain on top of it. So they may have chronic back pain, and on top of that, they have cancer pain. The pain itself could be from mucositis. It could be from chemotherapy-induced neuropathic pain. It could be nociceptive pain. It could be bone pain from Mets. So there's different types of pain that you're going to be dealing with. Mortality is high. Morbidity is high. Tumor involvement. I don't really have anything else on that one. So pain, fatigue, anorexia. Those are kind of major things with pain with cancer. So active treatment, these patients have significant pain, and then also patients who are, past active treatment and more so in just, their cancer is there, it's not being treated, they still have pain. I touched about this already. If their pain's not controlled, they're not going to do their chemo, they're not going to be compliant.
Do you still exactly follow like the start with low dose and escalate and escalate and escalate, or are you more willing in a patient with known aggressive cancer and involvement of other organs to just bypass steps and go to more advanced treatment modalities? Yeah,
so I think you still want to start with your step ladder, but you can move up more rapidly. So I have this patient who has I don't remember what her primary cancer is, but she's got abdominal mets. She's had multiple rounds of surgery, chemo, radiation. She's in some study trial. She has a life expectancy of less than a year. So when I got her, she was opioid naive. She's now on a fentanyl patch, and I'm still doing other things on her, but I kind of told her, this is what I'm going to start you on. In a week, if this isn't working, call me, we'll increase. Otherwise, if I have like a chronic back pain patient, I will tell them, we're going to do this for a month. We'll do physical therapy, and then in a month we can see what's going on and maybe make some changes. But I told her over the phone, just call me in a week and tell me what's going on.
And I hope I'm not jumping the gun, but I've wondered,
yeah,
you have this patient, like you said, your life expectancy is 6 months a year. Do you leapfrog into talking about like, hey, we're going to try to do like a plexus block on you, an ablation, things like that?
Yeah. So again, those are like your adjuncts. So you still want to be doing those things, but you don't want to be waiting on treating with opioids while you're trying to plan a plexus block or something like that. Let's see. So again, history. So you want to find out what their diagnosis is, what stage they're at, what therapy's been done, if they're going through chemo, where they've had radiation. And again, so these will give you an idea of where their pain's coming from, what's causing their pain, and what can be treated. So if you have a patient, they tell you that, hey, I've had chemo and now I have neuropathic pain, okay, well, I can use a neuropathic agent for this. Or if they've had radiation, that, okay, well, maybe they've got a post-radiation brachial plexopathy or something like that. So you want to get a good history. And then, again, we talked about the pre-morbid condition. So find out, okay, you had back pain before you had chemo and before you had surgery. Is your back pain okay, or is your back pain your primary concern right now? Because you can still knock off low-hanging fruit, right? So if you have a patient with abdominal pain from pancreatic cancer, but they have knee pain, well, you could still treat their knee pain and give them relief. So I'll just let you take a second to look at this. But again, there's so many different things. You can have tumor directly involving a peripheral nerve, soft tissue. You could have vascular pain because you have occlusion of blood vessels, necrosis. So, I mean, there's just so many different mechanisms. And these are not details that you need to know. We already talked about post-radiation neuropathy, peripheral neuropathy from chemo. So yeah, there's surgical pain. So if they have a thoracotomy, they may have post-thoracotomy pain. They may have a neuropathy there. Mastectomies, amputations, you can have post-surgical issues from that. And then acute pain from, if they're getting a biopsy, if they're going in for a surgical procedure just because they have cancer, they're still going to have acute on chronic pain. Oh, okay. So if they have back pain and they have cancer, do a full neurological assessment because they could, and in a lot of cases, have mets. So that is a big thing you got to watch out for. As if you're worried about mets, get an MRI, get a bone scan, and this is more so kind of board question, IT. Make sure the entire care team is on track. Make sure everybody's referred in. Steroids are great.
I have a question about
Yeah.
like, the team approach.
Yeah.
Would you go to like the tumor board meeting as a pain physician, or how do you like
Yeah.
get those people all involved?
So usually I end up sending my chart messages. So if there's something going on, I will send a my chart message to the oncologist, and I will just say, they're having increased pain. Is this something that you need to address? Are there additional scans to do? And I just kind of dump the ball in their court. But anytime they have an increased pain or a new pain or something that's out of the ordinary for the regimen or path that they've been on, I just try to loop them in.
Okay.
And that seems to be all they expect.
Okay.
And the same type of thing, if they're on chemo and you want to do a procedure on them, I usually will message them and say, hey, I would like to do a steroid injection. They're on chemo. Is this okay with you as far as, a further immunosuppressant? If their white count's low, just kind of loop them in. My chart messages or whatever, the epic messaging is the extent of my kind of looping them in. So if this is a nociceptive pain, so you're going to treat it with your traditional treatments. So NSAIDs, opioids, Celebrex, blocks. If it's neuropathic pain from tumor growth, radiation, chemo, then you want to use TCAs, SSRIs, SNRIs, steroids. You can do blocks. So you want to use short-acting and long-acting. So usually the breakdown is, about 60%, 50% of your analgesic requirement should be a long-acting. And then you still want to give them short-acting for breakthrough pain. So if they're, and again, this kind of really depends on what they're doing. So if they have pain when eating, they have pain with ambulating or dressing changes or something like that, you want to kind of treat for that. So if they're having dressing changes once a day and that's really their only painful time, maybe you just need like a once or twice a day PRN dosing. And then you just need something in the background for the rest of the day. So that's kind of your 50 to 60% for your long acting, 1/3, half for short acting. That's kind of the general thing. But again, you're going to treat it towards what their pain is, what they're dealing with. Again, just like all of our pain patients, everybody's going to have a different threshold of how much opioid they need, how much pain relief they need. One person's 10 is another person's 2. One person's going to be fine on Oxy 5. One person may need a fentanyl patch and Oxy 20. So there's so many other factors that go into this: age, what other pre-existing conditions they have, their mental status, addiction, cultural barriers, right? So in general, as Americans, I think we use something like 2/3, which is like 70% of the world's population, or the world's amount opioids, and we're definitely not that population. Just something to consider. Nice slide that I found. All right, so METs, bone tumor infiltration, is typically the most common cause of this cancer pain. It's usually a dull ache. It's not a sharp stabbing pain. It does get worse with ambulation, movement. And a bone scan is kind of the gold standard for diagnosing this, or an MRI. NSAIDs are great, radiation can work. But this is where that neurological exam comes into play. So you want to do a good neuro exam. You want to ask for red flag symptoms. So are they having changes to their bowel, bladder regimen? Let's see. Motor exam, right? Cord compression. So that's kind of your red flag stuff. So if that's the case, you need radiation, you need surgery, you need to treat them with IV steroids. So this is when you get that cancer patient, you need to make sure that you're doing a good H&P, because you can miss these things and they can have pretty serious consequences. Chemo, so oral mucositis, this is a big thing for head and neck cancer. So they'll go through chemo and they will have a lot of, just kind of blisters, and it really affects their quality of life. It makes it painful to eat, drink, swallow. So This is PCA, high dose opioids. There are some swishes you can try. Neuropathy. So some of these agents, vincristine, vinblastin, Taxol, they can cause really bad peripheral neuropathy. And it's just like any other neuropathy. So burning, tingling, but this comes on pretty quickly. And you're going to treat it the same way: gabapentin, Lyrica, TCAs, SSRIs, SNRIs. And then eventually, if they don't respond well to this, you can even consider spinal cord stimulation. We'll talk about that a little bit later. Post-surgical pain, again, the normal treatment for any other surgeries. Just keep those in mind. I'm going to gloss over this. There's a lot on cancer. I'm going to skip through some of these.
Say in the clinic downtown, what percentage of patients referred to chronic pain are cancer patients? Is it a high number, like if you're in practice?
Not really. I'd say probably 5%.
I was going to say, like Westchester, when we were there, I don't think I ever saw a cancer patient.
Yeah, so Dr. Sachdeva's got a clinic on Fridays in the Barrett Center. So that's a lot of the cancer pain patients. And then the rest of them kind of get dispersed throughout. The other thing is these cancer patients, it's pretty easy to treat them if you're a hematologist, right? Or an oncologist. You just treat their pain, and then if and when they get to a stable spot where their cancer is in remission and they're on a high dose opioid, if you're an oncologist, that's when you want to move that patient onward. But if you're actively treating cancer, most of the time the oncologist just treats them. So that's one reason why we don't see them. So this is more of an acute pain thing. So if you have a cancer patient in the hospital and you need to treat them, you can use a PCA. You can actually send some of these patients home, and this is more palliative care. You can send them home with a PIC and a PCA. If you really need to titrate their opioids and get them into a good analgesic regimen, you can send them home with IV. So intrathecal analgesia. So, let me back up. Epidural or intrathecal administration of opioid is also indicated for cancer therapy. So if you have a greater than 3-month expectancy, you can do an intrathecal pump. And if it's less than 3 months, you can just give them an epidural and just kind of change out the catheter every couple of weeks and treat them this way. If they have an expectancy of, I want to say, less than 6 months, you don't even need to do an intrathecal pump trial. So an intrathecal pump trial is a single injection of morphine, fentanyl, whatever, and you see if their pain gets better. It's a single shot, and you just see if it helps. If it's successful, then you can go on with the implant. Less than 6 months, you don't need to do the trial. You can just go straight towards it. But with an intrathecal or an epidural, again, you're using opioid, but you're using a smaller dose. So you're getting right to the spinal cord. And because you're using a lower dose, you have less side effects. So you have less of the constipation, the pruritus, the respiratory depression, and you get pretty good analgesic effect with it. Nerve blocks. So just like any other nerve block we do, if you have someone who has cancer pain from an arm or something like that, you can do a local anesthetic nerve block, but you can also use corticosteroid with it. So a lot of the blocks that we do on the chronic pain side of things, we use local and corticosteroid. And for some reason, there's lots of different theoretical explanations why, but these blocks last longer, even longer than you would expect from the local anesthetic block. So you do a medial branch block or a femoral block with, Marcaine and Kenalog. Marcaine should wear off in 12 to 16 hours, but the Kenalog somehow gives you pain relief for 2 months, 3 months, 6 months. So just things that you can still do. So don't forget about your basic stuff that we do for other procedures. So some of these interventional techniques, we're kind of getting away from just the cancer pain. These are applicable to all of our pain things in the chronic pain world. So there are sympathetic blocks that you can do. You can do the stellate ganglion block and the celiac plexus block. So these are going to be the two big ones that I feel like usually show up on the ITE. So we'll go through them kind of one by one. So your stellate ganglion block. So what kind of pain are you treating with the stellate ganglion block? Yeah, upper extremity, some facial, head and neck stuff, upper chest even sometimes. So the stellate ganglion is in front of the neck, like around the first rib. It's posterior to the common carotid artery. The vertebral artery is just anterior to the ganglion. So it's usually done under fluoro. I guess some people will do it under ultrasound. But again, it's a sympathetic block, mostly steroid, a little bit of local anesthetic, upper extremity. That's about all you really need to know for the ITE. Celiac plexus, so this is in front of the diaphragm, behind the stomach, near the celiac plexus, and the celiac artery and the abdominal aorta. So there are a couple different approaches to this. This picture shows a posterior approach, and you have the patient prone, you do it under fluoro, you kind of come in at an oblique angle, and you basically put the needle in front of the vertebral body. There's also a transaortic approach that you do anteriorly. You go through the aorta until you get blood and keep going until the blood stops. I have not done one of these. I have no interest in doing it. You can also do these under CT guidance. But this is for abdominal pain, pancreatic cancer pain, chronic pancreatitis.
Otto, do you have to get through the psoas?
Yes. But under fluoro, you don't see muscle, so don't worry about it.
I'm just imagining there's probably a lot of these patients that are on anticoagulation for whatever reason. And
Yeah.
an RP bleed or something.
Yeah. So this is not something you do when they're on anticoagulation. Yeah. I've only done a handful of these, but I do remember doing one, and so I injected the contrast, and I'm looking at it live, and I can see the contrast pulsating because it's on the aorta. So these are some very, very fun, satisfying, but very nerve-wracking blocks.
I imagine you use a small gauge needle as well, right?
Yeah, you're not using a 2, it's a 22.
When you get
Yeah.
blood return, it's like.
It's just pumping back, yeah. All right. These are some of the other sympathetics. So this is a lumbar sympathetic. So this is more so for like Raynaud's, urogenital pain, phantom limb pain, CRPS. So these are paravertebral ganglia that are, let's see, kind of around L4 typically. Again, you do this is a posterior approach, oblique. You're coming in and just getting ahead of the vertebral body. The hypogastric plexus, so this is more for colon, bladder, lower intestine pain. So it just makes sense, right? As you go further down, you're going to get further into like further down as far as the abdominal pain. So colon, bladder cancer, lower intestine, ovarian cancer, uterus. So this is around L4, L5. You get contributions from lower lumbar splanchnic, so that's L3, L4. Parasympathetic fibers from the pelvic splanchnic nerve, so that's like S2, S4. That's more than you need to know. Ganglion impart. This is a really satisfying one because it's really, you just go through the sacrum basically, that little ganglion impart. So this is right in front of that, just the tip of the sacrum. You go through the sacral ligament and just inject a little bit of local. So this is for chronic pelvic and rectal pain. It helps with like tailbone pain. Yeah, it's usually right at the top of the butt crack. Yeah.
And you go.
Almost like a caudal. So like if you were doing a caudal, you would be going in kind of like this into like this little notch right here. But instead, there's like the little sacral ligament here, and you just go through here.
And it doesn't ossify like.
It can be a little crunchy.
But not to the same extent as like the caudal where you're just like bang.
Yeah, no, it's not that bad. So with these blocks, so typically we just use local and steroid. Now you can do neurolytic blocks. Now these have fallen out of favor. I don't think I've ever done a neurolytic block. Not to say that they aren't done, can't be done. I think they're still fair game for your exams. So two big things, they use alcohol and phenol. So alcohol is colorless, but it burns like hell when you do it with alcohol. Phenol seems to be just a little bit of warmth and then numbness, but phenol is like thick, it's hard to inject, and it's not very stable. You have to mix it, and it's really hard to mix. I think that's more than you need to know, but those are the neurolytic ones. So this is now, This is now getting away from the cancer pain again, but just into like your bread and butter. So back pain is the most common cause of chronic pain. Number one reason we see patients in the pain clinic. It's big because it's the number one reason for patients to not work. Number one reason for, in general, not just pain management, but PCP visits, work absence. And I mean, we make a lot of money from back surgeries, right? We do a lot of this. So most people get better with time, okay? If it's a 1 week, 2 week, 3 week thing, they don't need to see us. They just need to do NSAIDs, ice, heat, physical therapy, stay active, no bed rest, none of this bullshit. Okay, so after 4 weeks, if they still have it, what does this show? So yeah, so really 7% of people only have pain 6 months after initial back pain. Like how many times have we all done like something, we strained our back, done something, and like it just gets better on its own, right? Same thing for all these patients. That small percentage that persists after 6 months, it's more and more likely that it's become chronic. Most people get better with conservative treatment. Very few people require surgery, and very few people have chronic pain even after surgery. Longer people take off work, the less likely they are to go back to work. Don't take them off work. I think that's it. So etiology for back pain. So this is kind of going from most common, maybe most common. So we'll talk about myofascial pain. So this is just a back sprain or strain, right? So these are muscle pains. Fibromyalgia I just kind of lumped in here because it's not really a diagnosable thing. Or is.
Tender points, man. Tender points.
Don't get me started on that. Everything is tender if you push hard enough. Okay, I can't see it on X-ray, so I don't believe it. All right, so myofascial pain, reproducible by exam, stiffness, tenderness, tender points. However, so over time, if you have these peripheral nociceptors, there's central sensitization. So these sensors, somatosensory nerves get ramped up. They kind of stay in this hyperexcitable stage. So you can still have chronic myofascial back pain. So treatments, heat, ice, physical therapy, NSAIDs, trigger points. Even the trigger points, the data behind them is really mixed. There's no evidence that local anesthetic versus steroid versus dry needling for trigger points is any better than the other. But some people help. So the bread and butter for chronic pain, radicular and facet pain. So you really want to diagnose with your history and physical about whether they have axial pain only or if they have radicular pain or a combination of both. So that's going to differentiate your treatment. So if they don't have radicular pain, so that means nothing shooting down the leg, nothing that would suggest nerve root involvement, you're going to really start thinking, is this facet mediated? So the facet joints are the joints between the different vertebral bodies. So this is, I mean, again, these studies are all kind of all over the place as far as numbers, but it's a common source of this back pain. So strain, repetitive motion, a little bit of trauma over the years, arthritis, a car accident, some sort of insulting injury can kind of set this off. Diagnosis is challenging, so we ask people to bend back and lean to the side. You're loading the facet. Well, if you load it enough, everything's going to hurt. If you bend back and lean to the left, even if you don't have pain, you will have pain. X-rays, imaging, MRI, a lot of people have arthritis on imaging, but we all know that just because you have an imaging finding doesn't mean that you're going to have pain from it. So the gold standard is to do the block. You inject it. So the medial branches come off of these your main nerves here, off of the primary dorsal ramus. These medial branches supply the facet joint. Innervation is not important for your exams, but the treatment, I don't think this is that often covered, but there are basically, you can do an intra-articular injection into the facet joint, which most of the time actually causes the joint to expand and cause more pain. So really we don't inject into the joint, we inject around the joint where the innervation runs. So if you inject with the local and steroid and they get immediate relief from the local, that's a diagnostic block. That tells you this is helping with the pain. So insurance usually requires you to do 2 diagnostic blocks, and then you can do a radiofrequency ablation which will last for 6 months to 2 years, and that's more long-term relief. And we'll talk about RFAs a little bit later. So radicular pain is that pain that goes down the leg, and that's usually from some sort of nerve root involvement. So you can have that from a disc herniation, spinal stenosis, and sometimes piriformis syndrome kind of masquerades as radicular pain. We're not really going to talk about that. Disc bulge over time. You can see some of these images. Basically, if you have a disc herniation, that disc is going to go somewhere. If it's going to press up against a nerve root and cause basically inflammation, irritation, compression of that nerve root, you're going to have radicular pain. Now, most of these people get better on their own. So you have a disc herniation, that herniation will go away on its own. The inflammation will go away on its own in most cases with just some time and physical therapy. The people that don't respond to that are the people that we do interventions on. So radicular symptoms are from the mechanical aspect, and then from the I guess the inflammatory cytokines that are released when you have that disc herniation. So we don't have good evidence, but we have anecdotal evidence, and insurance reimburses us for it. So we do epidurals. The goal is you're putting an anti-inflammatory right there, something to inhibit some of those inflammatory cytokines and potentially block some of these C fibers right at that site, have less systemic side effects. So we do these epidurals. Let's see. You can also do a discectomy, disc compression, physical therapy. We already talked about some of those. Again, most patients don't need surgery. This gets better on their own. Efficacy for epidurals, questionable. Does help with radiculopathy. For axial back pain, since again, you're not really treating a disc herniation, a nerve compression, you have more arthritis, and that's more kind of carried by those medial branches. Epidurals don't really help for low back pain. They help more for radicular pain. Okay. So these are just some images for epidurals. We do them. I don't think I've ever seen anyone not do it with fluoro. So there are different approaches. So an intralaminar epidural, you go basically through an AP view. You do a lateral to make sure you're in the right spot. But you can also do a transforaminal approach. So you do an oblique view, and you go through the nerve foramen into that space. And if you have a little bit more stenosis at that foramen, and you do an intralaminar, you may not get spread along that nerve root. And this is also to help as a diagnostic. So if you think that you have a L4 compression, the surgeon may send you a patient and say, I want a selective nerve root block or transforaminal ESI, kind of the same thing, at like right L4 to see if that's where I want to operate and if that helps their pain. So there's just different approaches to applying corticosteroid. SI pain from the sacroiliac joint can also masquerade as radiculopathy. So the little phrase that I use with patients is that the back is a complex place. There's lots of bones, ligaments, nerves, joints, and your hips, backs, and knees, everything lines. It's like the foundation of a house. So if one thing's thrown off, everything else gets thrown off. So you don't want to miss the other thing. So if they have back pain, but you see that they're walking with a limp, maybe you need to treat their hip, and that's going to help their back pain. So the SI joint is kind of the same thing. So this is a true synovial joint. However, there's no good diagnostic test for this. You can do X-ray, CT, MRI, but they're not reliable diagnostic tests. There are some provocative maneuvers, the Faber, thigh thrust. I mean, that's what insurance requires to approve SI joint injections. But really, the most reliable thing, again, is to do an SI joint injection and see if it helps. Again, just like every other back pain, this is not your first line treatment to do an injection. You want to use NSAIDs, ice, heat, physical therapy first. But if it's still chronic pain, you can do an SI joint injection. And this is just some distributions of where SI joint pain shows or presents. So, some of these look almost like radiculopathy. So you really need to be careful and do a good physical exam, and then unfortunately do some diagnostic injections. So spinal stenosis is another cause for neuropathy. So this is the classic, it improves when bending forward. They can push a shopping cart, they can walk, uphill, but downhill hurts. So you have a narrowing of the spinal canal, or even not just the spinal canal, but some foramen, and that puts pressure against the nerves or the spinal cord. So it's typically lumbar or cervical. I don't think I've ever seen thoracic spinal stenosis. Not to say that it can't happen. If you have lumbar spinal stenosis, you're going to get that radiculopathy that improves with bending forward. If you have cervical spinal stenosis, so that's myelopathy where you can have like full body weakness, paralysis, bad things. So imaging is important for this. Cervical stenosis is usually surgically corrected. So this is caused by a bunch of different things. So you can have ligamentous thickening, bone spurs, bulging discs, herniated discs. If you have the arthritis at that facet joint, that joint hypertrophies and it kind of gets thicker and bigger, that can cause compression. You can have a synovial cyst at that joint, and that cyst can cause compression and stenosis. It could be congenital. You can have trauma, tumors, anything that causes this sort of compression. Physical therapy, medications, weight loss, epidurals. There's something called a, what's this? I'm blanking out what the trade name for this, but this is a little intralaminar implant. It goes in straight, then you open it, and it kind of just pops open the space. It helps with compression. Surgical approaches are ACADF, laminectomy, laminoplasty, fusions. Do you guys know what the difference between a laminectomy and a laminoplasty is? Yeah, so yeah. So sometimes we do all these surgeries and we don't actually know what all the details are. I was guilty of this too. Sometimes. I mean, rarely, because well, we're good. So a laminectomy is when they actually take that roof of bone off, and that kind of gives basically more room to breathe. Laminoplasty, they basically shave it and just make it bigger. So those are some of the treatments, and of course, post-laminectomy syndrome. So that's when your surgeon has done everything. They've done back surgery, and they still have back pain. This is a new name for failed back surgery syndrome. It's the same CPT code, but the surgeons like this code better. It sounds a little less disparaging. All right. CRPS is going to always be on your ITE. All right. There's two types. Type 1 used to be called RSD. So you have some sort of injury, crush, surgery, fracture, ankle rolling, something happened. Type 2 used to be called causalgia. There's a specific injury to a specific nerve. It's the only significant difference that you need to know for your testing.
So type 2 is nerve specific.
Nerve specific. There was some injury. Yeah.
Not nerve specific.
All right, treatment sucks. There is nothing good about CRPS. It's hard to treat, doesn't get better, and usually I just tell the patient, you're going to live with this for the rest of your life. It's probably going to get worse. We'll try to make it better. Can't promise anything. Physical therapy, adjuncts, TCAs, SSRIs, SNRIs, physical therapy, regular therapy, sympathetic blocks. So this is the stellate ganglion blocks, the lumbar sympathetic blocks, and then spinal cord stimulator. So the diagnosis for this typically is Budapest criteria. There's some sensory, vasomotor, somatosensory, trophic changes, skin color changes, things like that you need to document. It's almost also like a diagnosis of exclusion. You want to make sure you're not missing anything else. You do bone scans. This is not relevant for you for your test taking, but just kind of know Budapest criteria, CRPS. Just know those go together. All right, a couple more topics. We're wrapping up here. Post-herpetic neuralgia, varicose zoster. This lies dormant in the dorsal root ganglion. That's usually, if anything they test you, that's what needs to be, that's what gets tested. So it reactivates when you're immunocompromised or immunosuppressed. So elderly, people who are otherwise, for some other reason, immunocompromised. It's usually thoracic or trigeminal. It can be any dermatomal distribution. And post-herpetic neuralgia means after the skin rash is healed, they still have pain. Let's see, some of the risk factors, age under 40, age over, under 40 is very rare, and then over 60 is the big one. Let's see, the worse their pain is during the acute phase, the more likely they are to have post-herpetic neuralgia. And then if they have it over the trigeminal distribution, they can go blind from this. Treatments, again, all the neuropathic pains, TCAs, SSRIs, SNRIs, gabapentin, Lyrica, capsaicin, lidocaine patches, sympathetic blockade, phantom limb pain. So there's a difference between phantom limb pain and phantom limb sensations. So people always have some sort of sensation of a phantom limb, but when it's pathological, we have to call it phantom limb pain. Most people will have it. There's no good reason or explanation for why. Let's see. I think the biggest thing I can tell you is the presence of pre-amputation pain is the biggest predictor of whether or not they're going to have pain afterwards. So post-stroke pain.
Wait, can I go back?
No,
You
sorry.
said
Yeah.
the presence of pre,
Amputation pain.
so like trauma or something else.
Right. So if they have a trauma.
Got it. Okay.
Yeah. So if they have a trauma and basically a quick amputation, they're going to do better than someone who has had, diabetic neuropathy for years and now they're taking their foot.
So those people will be worse.
Yes, if they've had chronic pain pre-existing. Because I think the theory is you have more central sensitization, you have more time for that central sensitization to occur, so that's why they don't do as well.
Sorry.
No, please, stop anytime, ask questions. There's only a couple more slides. Post-stroke pain, so again, this is really hard to identify. These pains are spastic, they have other issues for pain. Sometimes it's because they're not mobile or they're over relying on maybe like one arm for moving their wheelchair. So they may have shoulder pain, but it also may be contributing to or on top of post-stroke pain. So you have, again, these sensory pathways or somehow that pain pathway gets damaged from the stroke, from ischemia or whatever, necrosis. And then central sensitization on top of regular pain or normal musculoskeletal pain. So there's no good pathogenesis for this. Just know it's there. You got to treat it with opioids and TCAs and gabapentin, Lyrica. Gait control theory usually somehow shows up on ITs at some point every couple of years. Do you guys know this theory? Are you familiar with it? Melzack and Wall. This is something you guys should know. So basically, the analogy I like, you bump your elbow, what's the first thing you do? Rub it. So you're blocking a painful stimulation with a non-painful stimulation. So gait control suggests that if you have a painful stimulation, you can block it with a non-painful stimulation by closing some of those pathways. If you know that much, you'll be good. So your A delta fibers are your fast, well-localized pain. Your C fibers are small, unmyelinated, slow pain. But you also have A beta fibers, and those are kind of the intermediate size. That's myelinated sensory pain. That's, myelinated sensory conductivity. That's mild pressure, touch, vibration, your joint position. So you're trying to activate your A beta fibers, and then you block the A delta and the C fibers. So this is the theory that we're trying to use when we use a TENS unit or a spinal cord stimulator. So a TENS unit, you're activating some of these A beta fibers, and you're blocking the C fibers, the A delta fibers, and this is transcutaneously applied. There's no good evidence, but it's better than placebo. We'll take it. It's low risk. Basically, don't put it over someone's head. Don't put it over their pacemaker, over an open wound. Spinal cord stimulator is using the same theory. However, we're doing it by putting epidural into the epidural space. We're putting these transcutaneous catheters for the trial, and you're putting electrical signals towards the spinal cord, and you're covering those areas with paresthesias. So the initial way spinal cord stimulator came out was you were literally trying to cover where they have pain when you do these trials with the paresthesias. Now you can also have paresthesia free, and the theory with that is the frequency is so high that they're not experiencing paresthesias, but you're still having chemical changes to the neurons that are blocking the pain. You're still blocking the pathway. I don't think you really need to know more about this process. Clinically, we do a percutaneous trial. They wear it around for 5 days, 7 days to see if it helps their pain. If they like it, they get an implant. It's done usually under MAC. batteries are rechargeable, or some of them last for 5 to 7 years, and then you just swap it out. Radiculopathy, CRPS, those are the main indications for this. Axial back pain doesn't really work well, but radiculopathy, great. Radiofrequency ablation, we talked about this a little bit earlier. So basically, you do a diagnostic block with local anesthetic to confirm that this is the nerve that you want to target. Then with radiofrequency ablation, you're using like alternating current radio frequencies to heat up the tissue to cause a lesion. You do it under imaging guidance, so ultrasound, CT, fluoro. The medial branches of the facet joints is a big one. Genicular nerves for chronic knee pain. This could even be done for post-surgical. So if they've had a knee replacement, still have pain. Those are kind of the big ones. Cryoablation used to be done. I've never seen a patient who does it. We do radiofrequency ablation, but with cryoablation, they would use these big ass needles, 12 to 14 gauge needles, and put the probe through it. And then the probe is cooled with like nitrous or carbon dioxide. Dr. Crone had a patient who she would do cryoablation on for like a mandibular nerve. And this 14 gauge needle went in there every 3 months or 6 months. So the patient just had a hole that was just like I mean, it had healed, but I mean, you didn't need to look. You just went into that hole with this big freaking probe. No one does that anymore. The machine broke. So the patient, and we were like, we don't do this. We don't have this machine. So the patient bought their own machine used and brought it in so we could do it.
Oh my God.
Yes.
Wow.
Yeah.
Was she willing to do an RFA instead, or was she just so hooked on the cryoablation thought?
The patient was not having any other thing. She was like, this is my doctor. This is my procedure. Cryoablation. Yeah, that's why I was here. Cooled RFA is a newer thing. But basically by cooling, there's some like water channels in this needle. So by cooling it, you can decrease the temperature to prevent necrosis, but you can apply more energy to the tissue, so you get a bigger lesion. So you can see cooled RFA is on the left. You get a more circular lesion. With traditional RFA, you get a more oblong lesion. So when you do a traditional RFA, you want your needle tip kind of parallel with the nerve. You don't want to go right onto the nerve because the tip does not really give you a lesion. You want to lay the needle tip against the nerve. So cooled RFA makes it easier to be a shittier provider and worse at your job. That's it. This is a lot of stuff, but again, like I just try to focus on like things I thought were high yield for the ITEs. What questions do you guys have? I'm sorry for all the information and all the text on the slides.
When you're prescribing opioids, what do you do about people in terms of like advising them about driving, working, machinery, things like that? I'm just curious.
I put a little dot phrase in my note that says that I talked about the risks.
But that you're not afraid like legal with that dot phrase, that's all you need to do.
So you tell them to avoid things until they know what it does for them. So I always tell people, take the medication the first time, maybe when you have a day that you're not doing something, so you know how it affects your mental status. And then I always tell them that like you should not be driving or doing anything where you're going to put someone at risk when you're on these medications. What they do on their own. But realistically, I mean, the majority of these patients are probably taking opioids and doing their normal day-to-day activity. But again, this is more of a CYA thing.
Like that stepwise approach, like if you have someone with chronic back pain or cancer pain, let's say cancer pain in particular, because we talk about it a lot, you just start them on a long-acting opiate, like baseline therapy, and then give them a breakthrough medication first, or just give them breakthrough medication, see how they do, or does it just kind of depend on what their symptoms are throughout the day?
So I usually like to start them on a short-acting and see what they do, because sometimes you'd be surprised. Someone may just do fine with Percocet 5 3 times a day. And if they're on something such low dose, I don't think it's worth starting long acting if you don't need to. So I can't really draw on anything anymore. There's no whiteboard. So think of like your short acting as like peaks and valleys, right? So if those valleys are low enough, you either need to go to a higher dose or more frequent dosing so you avoid those valleys, or you add that long acting. But there's no right or wrong answer to this. But insurance usually doesn't approve the long actings until you've tried short acting and you've documented that it's not working. And then you have more, I think also more of an increased risk if you're at a low dose and you're starting them on a long acting. Not so, I mean, the medication is a lower dose usually as a long acting and it kind of stays on the background. But if they don't need it, why are you giving them something that's kind of always going to be there if they don't need it? If they're doing fine with BID, TID dosing, it seems like overkill. You know, maybe they're doing fine at night or during the day. What's that noise? Okay. Any other questions? What is this thing?
Hey, Otto, this is Will Pitman, dude. How are you?
Hey, Will. How are you, buddy?
Dude, doing awesome. I caught the last 10 minutes of it and realized how much I've forgotten in almost 3 years.
Oh, that means I like learned so much in the past like 2 days.
That must be what it is. Do y'all do any mild procedures?
We do not. That's because UC doesn't let us.
That's been taken off down here in
Please,
Knoxville
already.
recently, and they seem like the patients are doing really well.
Yeah, so it's like you're basically doing a discectomy, but minimally invasive. So you're doing it percutaneously with a little bit of sedation. And again,
Damn.
you're just opening up that space so there's more room for the nerve to breathe. That's the analogy I like to use. UC, I think, won't let us do it because it takes away from the surgeon's money.
Yeah, dude, the neurosurgeons here are not very happy about it, but the recovery time's obviously a lot quicker. And like I said, the couple that I've done so far, I've talked to the patients and they seem like they really like it.
Yeah, it's phenomenal. It's just, you know, there's politics at play with health systems.
Yeah, I get you on that.
All right, anything else, guys? All right. So I have you logged in on my computer, so I should probably log in on the regular computer so I can take my laptop and leave. I didn't think about that. No.
That's all right, Otto. I'm going to try to request control on this.
We may lose you for a second while I log in.
Out of my wheelhouse.
Thanks, Otto.
Maggie? What are you below? What's your date? But there's zeros up there? Yeah, there's optic.
But the current debate is if he is actually
Oh, what do you do when you inherit a patient that is on like 120 oxy a day?
Find a reason to dismiss them.
Yeah.
So I usually, I just straight up tell them that like I'm not comfortable with this and I'm gonna wean you. And I hope they leave.
I just feel like my experience of at Westchester, like there were people that I don't think are doing a service to.
Hey guys, can any of you all hear me that's still connected on this call?
Yeah, I hear ya.
Awesome. Are we waiting for the main group to come back in, or how does that work?
No clue. Luke Olson, can you please talk on behalf of the main group, sir?
I feel like when Otto is switching his computer around.
Hey, Will,
he may-
can you
hear us now?
Yeah, I can hear you guys.
Yeah, we
Oh,
can hear you nice and clear, so you
Sweet.
can get started whenever.
Awesome. I tried to request control so that I could get my screen up here. Do you know anyone of you guys? I don't use Microsoft Teams all that often. Do y'all know how to do that?
Can you try to just share your content? Because we can see like your face real big right now.
Okay, that's probably scary for everybody. So let me see.
I like your window shades there in the background, bud.
Yeah, man, this is what you get living in the attending lifestyle. So
Hey, Will, aren't you from Baltimore?
I am not.
James.
Peter Airball is from up there.
Are you from the South?
I am from Western Kentucky, so south of Cincinnati. So can you all see the PowerPoint pulled up where you guys are at?
I saw it for a
We
second.
did for a moment and now we don't.
Okay, let me try this again.
Oh, there it is.
There it is.
Y'all can see it? Sweet. Now let's see if I can get this into slideshow. As you can see, this is super professional. Can you all see this here? Or is it flashing again on you?
Try to go to the next slide, maybe.
It's just black.
Black?
Yeah.
We can see your mouse.
Yeah, it's flipping back and forth on me. I can just show it to you, I guess, without pulling up the PowerPoint presentation. Guys, while we're getting this going, thank you all for letting me talk. Let's see, we'll take that off for a second. Open share tray, PowerPoint slideshow. Shoot.
However you had it before when you weren't sharing your slideshow, we could see it.
So just like this, you guys can see, or no?
Give us
No.
yeah.
Yeah, I can see it pop on mine, and it is just flashing like crazy. It's probably because my computer is old and.
If you go back to like a not present mode, we can see the individual slides and like it has them in the side column that you can just flip through. Yeah, like we
Can
can
y'all see that? Okay.
Yeah.
Sweet. Well, I will try to. Let's see here.
There we go.
That gonna work well
Looks
enough
great.
for you guys?
Yeah, that's good.
All right. Well, guys, thank you all for coming and listening today. For those of you that I don't know, my name is Will Pitman, and I asked Donna and Howery Shuck and Dustin Saturis about being able to speak to you guys. And what the goal of the talk today is going to be is how to live your best life or reach your highest potential through intentional living. And I want to introduce myself to you guys. For the ones of you who don't know me, I was at the University of Cincinnati as a resident from 2015 through 2019. That last year I was there, I was one of the co-chiefs. And since leaving, I moved to Knoxville, Tennessee, where I practiced just general practice anesthesiology. More importantly to me, though, I am a Christian, I'm a husband, I'm a father to two amazing kids. And over the last several years, my wife and I have really tried to figure out how do we live the best possible life we can, regardless of any external circumstances. But before we get into that, I wanted just to say really quickly, as I'm sure you guys know, the training you all are getting at Cincinnati is really awesome. So at the end, if you guys have any questions about private practice, I'm happy to answer those, but I still do hearts, neuro, vascular, Basically everything except for trauma and transplants. Do all my own lines and blocks and staff a pretty busy private practice ortho surgery center where I'll do 35 to 40 peripheral nerve blocks by myself every day. So what you all are doing right now is really going to prepare you to pretty much do whatever you guys want to do when you are done. So the three main points that I want to hit here is how I've stumbled my way through figuring out what intentional living was in my own life, how you guys can do that yourselves, and then some of the potential roadblocks that you may hit along the way and how to kind of transmute those fears or failures into more success. So as everyone always says, do as I'm telling you to do, don't do as I did in my own life. So I can break my professional adult life down into about 3 distinct visions. So at first, I really had no idea about the topics that I'm sharing with you guys, and I don't even know, if I'm honest with you, if I would have believed them when I first heard them. So when I got into medicine, it was pretty lackluster. I really excelled in school and high school and through college, but I never really gave much thought to my future. And this doesn't even just mean from a medical or professional standpoint, but I had really no idea on where I wanted to live and how I wanted to live, even if I wanted a family or what kind of living space or what I wanted to do with any of my stuff. And as vain as it was, my only passion at that time that was serving kind of any positive influence was that I liked lifting weights. And I'm actually going to circle back to that at the end of this talk to see how that kind of comes back around when you follow your own heart. But what I figured out was if I didn't define what I wanted out of life, I was allowing other people to do that for me. So just from, I think, well-intentioned family pressure, I was kind of told to pick a high-paying career, which nudged me towards medicine. I was in a relationship at that time that was pretty unfulfilling and somewhat volatile, but because I was scared to leave it, we ended up moving in together at the end of college and the start of medical school. And I fell prey to a lot of different things. So addictions such as drinking, partying, and other things that gave me a pretty tumultuous personal life as I was going into med school in Lexington, Kentucky. So as I'm sure you guys remember, as soon as you start studying with medical school, you realize that there is a ton of stress that comes with that as well. And so a couple months in, I felt this crisis of being alone and trapped doing this job that I potentially didn't want to do in a city where I didn't know very many people and had obligated myself to be financially for the next 4 years. And while that can sound like a sob story, I think this pain that I was going through was the wake-up call that I needed for me to live my perfect life. So really quickly before I jump off here, I've got this quote by Dr. Joseph Campbell and a YouTube documentary flagged by him. It's a great watch that kind of tells you about his life. This man was great at going through different kinds of human philosophy, but he talks about pursuing your life with intention and seeking joy in what you do. And I think as I started going through this, I realized I was unconsciously following the path that he states that all humans need to go through. He calls it the hero's journey. And as you all dive into this for yourselves, you'll realize that you're very well on your own specific hero's journey now. It just depends on what part you're in and how awake you want to be as you're going. So as we said, since I wasn't willing to define what I wanted out of life, I pretty much at this time was dooming myself to repeat variations of the same lessons over and over again. After cutting some old social ties and getting out of bad relationships that weren't serving me, I found myself sitting around wondering what the heck am I going to do with my free time while in medical school to try to de-stress and bring some happiness in. And as cliche as it sounds, I found CrossFit at the end of my first year of medical school, and more importantly, found a group of people who valued health and fitness in the same capacity I had since a young age of 13 or 14. So CrossFit became this sounding board for me to begin to dream about what I wanted out of life. I still had no idea what I wanted to practice in medicine, but I knew that I wanted to have a lot of time and energy to focus on functional fitness as much as I could. So this first attempt at planning ahead led me to consider some careers in medicine that had more shift-based type work. And so after looking at things like emergency medicine and anesthesia, I ended up finding this discipline in medicine that was pretty exciting to me. So as I started following this unique right path, wonderful other things started to happen to me. Because I got into CrossFit, I met my future wife through the connections I had at the gym. And just as a quick aside on that, my wife had actually been in a previous relationship that was not really serving her. And when she got out of it, she actually sat down and intentionally wrote out what she wanted in her dream partner. And so this was all very specific things on how they acted, how they conducted themselves in life, the kind of job they wanted, what their dream aspirations were with children. And while I don't know if I necessarily live up to all of those, she very lovingly states that I did. And that was how she kind of sought me out as well. So this is towards the end of medical school for me, and we quickly fell in love. But we're at the end of my 4th year of medical school, and we're kind of worried about the long-term success with this new relationship as we're getting ready to go through match and not knowing where I'm heading it. So anyways, I followed my heart because I loved her, and I think that was some more unconscious dreaming on my standpoint. And so I rearranged my rank order and tried to stay as close to Lexington, Kentucky as possible. And once we finally matched in Cincinnati, we were still kind of nervous how residency was going to affect our relationship. But again, the universe kind of brought us together. And a month after match, we found out that we were pregnant with our firstborn Wilder. So at this point, we've started this new life together. So we're going to skip ahead a little bit into residency. And we found ourselves as a young family with 2 kids under the age of 2. My wife was super proactive about researching schooling options, nutrition, different kinds of clothing, and all these different stuff with our kids that she wanted to set up. But I had pretty much reserved myself again to riding her dream to the next stage of our life. However, she intervened with that, and we read a book together. And at Kimmy's suggestion, we came across this idea of a vision board. And what a vision board is basically just a tactile way for us to design our lives to try to maximize our time as a family back then. So in other words, what we were trying to do is figure out our dream as a family and how to accomplish it. And so this next slide shows a picture of our first vision board we made sometime in late 2016. Well, I guess early 2017, because my daughter was born early 2017. And kind of tried to design on this poster board how we wanted our family life to go. So we placed a picture of our family in the center, and then we thought of all the different decision trees that we would have to make and put them around the periphery. So I know it's probably hard to see, but we envisioned following areas like what my job choice would do to influence our family, our financial goals, our traveling and other purchases, what kind of home and property we wanted to own, our social network, the kids' schooling choices, my wife and mine and our family's health and wellness practices, and then our spiritual needs. And so by having this, it gave us a way to navigate through a bunch of life decisions and say, is this going to serve our family as a whole, or is this going to actually detract from us as well? And so since we did this, we came up with a lot of really cool stuff. So by making this vision board, all of this stuff on this bottom here with things that directly came off of it. So our goal for our job and lifestyle was to move to an outdoor-based town that had year-round activities, but that was still within driving distance of Lexington, Kentucky. So once we made a map or looked on a map and made a circle of all the towns that would fit that criteria, Knoxville was our #1 choice. And so we came down here and quickly fell in love with the town and decided that's where we wanted to try to get a job. I looked through what I wanted in a job after going through residency and figured out that I valued more time off rather than extra money, and wanted a more relaxed call schedule where I didn't have to do trauma or transplants. I know all you guys can commiserate with that when you have to do a liver transplant or something comes in overnight, you're not sitting down and not sleeping. So the first place I applied to down here in Knoxville, they seemed to on paper have all of those values that I wanted. And after coming, I really hit it off with them. And within 24 hours of finishing that interview, they had sent me a contract and I was beginning to sign to get that job. So as we started following our heart, I hope you see the pattern that as you make one decision that's positively benefiting you, you will start going down the path to make more and more for yourself. So now that we've locked in a job, we wanted to find non-traditional schooling for our kids. So my wife was really interested in our kids learning from their peers and having a lot of interactions outside of a normal classroom setting. I didn't want our kids to be sitting in chairs for 8 hours a day where they could get up and move and spend that time outside. And so when we were in Cincinnati, we checked out this Waldorf school. And if you all are interested or you have any kids and you've not heard of Waldorf schooling, I highly suggest looking it up. The school in Cincinnati is great. Unfortunately, they didn't have that here, but they had a Montessori school that was nature-based that went from preschool through 8th grade. And so after we found that schooling and decided that's where we wanted to go, we started to look for a house. And looking for a house even pre-housing spike after all this stuff with COVID was pretty crazy in Knoxville. Everywhere that we were looking that people told us were the popular places to live, we couldn't find a house that we were really in love with, because what we wanted was a lot of land. We wanted to have space for our kids to run around and for us to do workouts and be outside a lot, but also on a budget. So we'd kind of set, $350,000 or less because we didn't want to be house poor paying off our mortgage every month. And as soon as we sat down and took a deep breath and said, hey, we are going to spend most of our time driving our kids to and from school and me going to and from work, we expanded our search to, quote unquote, the less desirable parts of Knoxville. And within, again, 2 days or so, found this house. It was about 3,500 square feet. It was divided into 2 different big compound rooms. So there was a main living house, and there was a detached garage that ended up having our gym, our kids' playroom, and a mother-in-law suite. And then it was on 3 acres of cleared land. It had 17 acres of woods in the back that were undeveloped. And Carl and Christina have been there before. It was just an awesome sanctuary for our family. But because we decided that we wanted to live in a place that valued our family, not in necessarily the popular part of town, we ended up finding this perfect house for us. And so while I would say that not everything in our lives were perfect when we moved to Knoxville, we had this very concrete dream in mind. And so we were able to sift through all these endless possibilities and relatively easily navigate these decisions based on our desires from that vision board we made. But as you guys know, life really isn't stagnant, and neither are we. And so after we kind of evolved and continued to grow here, we ended up outgrowing that vision board and made some changes. As COVID hit back in the early spring of 2020, I know you guys, the ones that were in residency, realized that, I know we had some reduced shift work. I found myself at home a lot too. I was working a lot less and had a reduced salary at that time, which was somewhat scary. And so Kimmy and I had a lot of time to talk and pray about what we wanted to do in our life and what we really wanted to value. And what we realized was that after we kind of finally arrived and acquired this material kingdom that we thought we wanted, we realized that that wasn't what was making us happy, but what was actually making us happy was the things that those materials provided for us as far as time with our family, quality experiences, and keeping our health and wellness up. So as all this is going on, we are dealing with all the societal and social changes that we were doing in the pandemic. But we decided, as we're going to reevaluate our dream, we were going to consciously try to manifest our perfect lives rather than doing this unconsciously or without thinking about it. And so here were some of the things that we started working on then. With COVID, this awesome school that we were sending our kids to, they unfortunately began to abandon the philosophy of Maria Montessori as far as how they did their teaching and styles. I think out of fear of being shut down, and pretty aggressively started enforcing mask mandates and social distancing. We didn't pick our school as that was our end goal. Our vision for our kids was that they learned in this way where they felt surrounded by their peers that were loving. They got to be outside and move around, and they had teachers that were able to care and share and connect with them. So while there were a lot of parents that were struggling with if they wanted to send their kids back to the school and continue to pay tuition to go there, we pretty easily decided that the best thing for them and for us was to pursue homeschooling. And so my wife ended up getting certified to teach homeschooling for Waldorf education, and we have been flourishing with that. And because we listen to our hearts, not only is my wife doing well, our kids have been doing awesome through kindergarten this year. Throughout this too, my wife kind of realized that she had a big passion for helping families, and specifically helping women who had families with young children live a life that was more conducive for health. And so she changed her career from doing insurance for 10 plus years, ended up starting her own business, which I'll plug at the end of this talk, where she does coaching for that, and has been really inspiring to a lot of people here in the Knoxville area and to other people online as well. We also realized that while it was fun to be in Knoxville, we also enjoyed a lot of time at the beach. And so during 2020, even with all the lockdowns, we decided to see if we could travel to the beach several times. And we went 4 weeks that year, and then 8 total weeks last year. And we have about 10 planned this year. Our family really thrives being out in the sunshine and in the water. And so we realized that if we can have the time to do that, we might as well take it as much as we can. And then the final thing I saw on here was we had a reduced salary that I thought was pretty well solid, because so many people are always having surgeries, and that anesthesia seems like a pretty stable career. But with COVID, that can potentially go away. So with the volatility of getting a paycheck potentially, and then seeing that our student loan interest rates had been paused, we made a goal to pay off all of my student debt, which was about $240,000. So almost to the day of graduating residency, we paid all of that loan debt off in 26 months. And then there's a couple other really big things that we're doing. We have to wait until mid-April or so, but we're going to announce those on our social media channels in about a month. So if any of this stuff has been interesting to you guys, I will be happy to plug that as well, so you can follow along with those. But what I want to say before moving on from this slide is I wasn't making a ton of money to go to the beach and doing all this stuff. So in 2020, I was grossing $250,000. and in 2021 grossed 350,000. And then this year I'm kind of capped at my salary at 425, which is much better than 250, but we're not making seven figures here to make all these trips and do all these things. And so how the heck did we do this? We listened to God and to our own instincts and intuition kind of as opportunity was arising. As we kind of mentioned before, we didn't want to settle on our dream. And so when external circumstances changed, we would take those difficult decisions and continue to prioritize whatever was best with our life. So we already kind of talked a little bit about homeschool of why we made those decisions. Skipping ahead a little bit to the beach, we didn't stay in fancy places or five-star resorts. We were really meticulous about scanning through Airbnb and VRBO to find some really ridiculous deals on staying in condos and houses. And we very rarely ate out when we went on these trips. We just valued time at the beach and spending this time together. So we figured out that we could take these cheaper trips and have the ability to go more often rather than living lavishly and doing it once or twice a year. And then with our loans, you know, besides doing these beach trips, we were super conscious about where our money was allocated. So for a little while, we were paying for our kids' schooling, and we spend quite a bit of money buying high quality organic food. But besides that, that's about it. So we were throwing a ton of money towards our loans. But again, we realized that money wasn't going to make us happy. Just having the freedom and having the financial independence would be the best thing for our family in the long term. And this led us to this concept that I've got written up here called trading what you love for what you love more. In 2021, the housing market here in East Tennessee just went insane. And we loved our house that we lived in, but we realized once we had it that while the land was great, the house was much too big than what we needed. And we struggled for a little while. Do we want to sell this house and potentially find another place to either build or find a non-traditional home site? We're eventually wanting to do some kind of tiny home or semi-stable structure to live in. But we didn't know what we wanted to do. So after kind of praying and listening to ourselves, we had this big desire to say, hey, we're going to list our house very high above what we bought it for. And if we get any bites on it, then this was the time to sell it. And we ended up going camping that weekend. And within 48 hours after we got back, we had over a dozen offers that were even higher than our asking price. And by the time we closed on our house, after paying closing costs and negotiating a little bit on the roof, we ended up getting a check from the bank that was within exact $16 from the remaining $127,000 I had left to pay off on our student loans. So I say all that to say that sometimes the way that you envision something happening may not play out in the exact timeline or in the exact way that you think, but if you remain open to all the gifts that we have around us, things will end up happening in a way that I couldn't have ever possibly imagined. So I didn't know that the housing market was going to do what it did. We just knew we wanted to pay off our loans. We had a deadline of 2 years to do it. And like I said, we just went a little bit over 2 months of that, but paid our loans off and are living easy from that standpoint. And so why am I sharing all this stuff with you? I'm not doing it necessarily to brag, and I hope that it doesn't come across that way, but our family is nothing special. And what I don't think that is sometimes lost whenever I'm talking to people about this is we weren't lucky, and I don't think that we were genius in anything that we did. But what we realized, as many people have before me, is that we have much more control over our lives than we care to admit. This quote at the bottom is from Marianne Williamson, and I love it. It's, "Our deepest fear is not that we are inadequate. It is that we are powerful beyond measure." And then she goes on to say that it is our light inside, not our darkness, which most frightens us. Our society is set up very compartmentalized and wants us to kind of feel inadequate on our own. And if we do that, then we stay dependent on the system for goods and services, and that ensures that money exchanges hands for everything that we see around us. But an unfortunate byproduct of this is that it promotes this widespread discontent and unhappiness because we feel like that we don't have enough unless we have purchase A or know person B or go to place C until we can feel this whatever sense of fulfillment that we're lacking. But that mental and emotional disease that we internalize will spread out into our physical bodies. And when we are unsatisfied as a person, that leaches out into our peer circles, our friends and family, and then even further goes out into our society. And is one of the major driving reasons, in my opinion, that we see the most unhealthiest group of population of humans that have probably ever lived on this planet. And as physicians, this should really bother us because we all swore a Hippocratic oath, either literally or figuratively, to promote health to our fellow man. And if we can't even model this for our communities or even for ourselves, then where do we expect to find this catalyst for change? And how do we begin to heal ourselves? I believe this doesn't really come from any specific medical text, but this is going to come from each of us intentionally living our own lives. So I had asked Donna to send this out to you guys. I don't know if it came through in an email or not, but one of the questions I had was for you to try to think about what is your biggest dream in life, or what is the most important thing that you can do to live the best life that you can envision. This involves sitting down and taking time to figure out what makes you happy, provides passion, and it gladly steals your time and energy. And I'll go back to when I was kind of not really having a vision for my life. If you don't pick a dream, someone else in your life will do that, and you will start to follow along with it. And I promise you, whatever their idea of a life for you is, it's never going to be as good as the one that you pick yourself. And so if it's kind of daunting and you haven't really figured out a way to figure out, I guess, what your dream in life is, the best way to do is to reverse engineer this problem and find things that you're doing right now in your life that aren't serving you and brainstorm ways about how to eliminate them. So I'll give you a bunch of examples in my life. My dream that I've told myself for the last several years is I want to be the living embodiment of health, not only for myself and family, but for those around me. And so over the last 5 years, I found a lot of different incongruences from what I was saying that I wanted and how I was actually living. So I've broken numerous addictions to things like inorganic and processed foods, late night eating, pretty much all types of media, including television, smartphones, social media platforms, multitude of supplements, energy drinks, coffee, marijuana, over-exercising, overpacking my day, cutting back on my sleep, and basically a lot of ego-serving activities that I was trading for short-term comfort that were hurting me in the long run. But what I've found is each time I've broken one of these habits, I've been more liberated to be in tune with myself and my family. And I continue to do a lot of this healing work so that every day I become more and more fueled and inspired to connect to myself and the world around me. And I think regardless of the dream you pick, as you begin to live that life and bring that into fruition and creation, you'll feel the same way too. So all of those steps to do that, though, involved me rewiring old habits that I had and creating new ones. And the big thing with that people have to do is you have to grant yourself grace, because that takes both time and energy. And until I found the energy within myself to make these changes, I would just fail over and over again, which is really frustrating when you're earnestly trying to do something and it just seems like it's not happening. But the big key to that was this kind of arrow line I've made here. When you focus your thoughts on what you want out of life, it creates this internal desire for change. So our thoughts are more powerful than you can possibly imagine. We'll talk about that here in a second with the law of facilitation. But everything that's ever been created in this world, from every anesthetic drug you use to the computer screens that you're looking at, to the light bulbs, to cars, to everything, all of that started as a thought in somebody's head. And that thought grew into desire inside of them to help create this thing or this place or whatever it may be. And that grew into them talking about it. So they talked about it to themselves. They talked about it to their friends, their family, to let them know, hey, this is something I'm truly passionate about and want to create. After that, they started taking action, and they may have worked and worked and worked on it. It's the old story of Thomas Edison failing a million times before he made a light bulb. It's you continue to do it because you have this internal drive and desire to make something that's going to better your life and the people around you. And eventually, you'll create it. And everyone has the power to do that. We just have to remind ourselves that we have that within us, just like everybody else does. And so I came across this idea of the law of facilitation, which is this neurophysiologic concept that pretty much anytime you have a repetitive stimulus, we grease our synapses to be more efficient for that the next time we do it. So same way as you all learn how to intubate, the first couple times you do it, it's really scary. You're not exactly sure what you're looking at. And by now, I'm sure most of you guys can stick a laryngoscope blade in someone's mouth, and it is not daunting at all. Your body and brain immediately finds where you're looking for, and you can put an intratracheal tube in. So that's a positive neuronal pathway that we can create. But unfortunately, we make a lot of unconscious negative pathways through chronic negative self-talk. But just as you can learn how to do things in your life, everything from tying your shoes, riding a bike, up to practicing anesthesia, you can unlearn these behaviors if you put in intentional practice and try your best to change it. One of the other things I want to mention before we leave this slide is that your dream can literally be whatever you want it to be. It should be totally different from mine because we're all unique individuals. But the big thing is you've got to sit down and spend some time figuring out what truly is bringing you joy in life. Because if you don't, you may very well be living a much better life than you're realizing it, but you've never taken the time to think about it, and so you don't know if you've ever achieved it yet or not. So an easy place to start with this is with anesthesia. So how much fulfillment do each of you guys get from your work? Some questions to think about as you're going through residency is what parts of anesthesia are most fun for you? Do you enjoy sitting cases? Because there's plenty of jobs that you can work MD only doing that. Do you enjoy doing certain types of procedures? Do you enjoy managing rooms? Do you specifically enjoy a certain rotation or subspecialty? Once you figure that out, you can expand that into your personal life. So you know what kind of job you're interested in finding. Figure out where do you want to live? What kind of time off are you looking for? I think I had that on a slide earlier. I didn't mention it. So when I started my job, we had 9 weeks off a year and then had 2 days off post 24-hour call. We've rearranged that since then. And right now, basically, I'm working on a 3-on, 1-off schedule. So I get 13 weeks off a year, bookend weekends also where we're not working calls. So you can find whatever job you're looking for and make it fit your lifestyle. You just have to know what it is before you start looking. But going back to that, do you want to have a family? Do you want to be close to other special friends or family within your life? And then what hobbies do you like doing? If you're super into mountain biking, for instance, do you want to live near a place that you can go mountain bike every day when you get off of work? And there are literally thousands of jobs that you can find within anesthesia. And if you don't know what you want to do, every one of them are going to sound good because I promise they're going to pay better. You're going to have more time off than you do right now in residency, and you will become a victim of circumstance. I'm sure you guys can name several people who you've seen leave Cincinnati to go to a different job and end up coming back. Not necessarily that job was better or worse, and not to judge that person, but I bet you it sounded much better on paper than it ended up being, and they didn't know exactly what they wanted to do when they left. But if you can create that perfect dream job in your own mind and then seek that position out, you will find it every single time. And then last thing on this, don't be afraid to evolve your dream. So as you grow, you're going to change just the same way that our physical bodies have done it. All of us are different people than when we were 10 years old or 20 years old. And I hope to goodness that as I continue to grow and evolve, when I'm 40 and 50 and 60 and beyond, I am a much different person than I am now. And we can conceptualize that within our own bodies, that our cells and tissues regenerate all the time, but so can our mental and emotional capacity to learn. So as we are growing, don't be scared to separate from old thoughts or habits or behaviors just because they feel comfortable. If they're not serving you to live your best life or this quote unquote perfect dream, then figure out a way to get rid of them. And so you make more room in yourselves and in the people around you to live that life. And again, we have more huge announcements that Kimmy and I are going to do with our family coming up pretty soon. We just have to wait a little while to talk about them, but we're super excited about that as well. So this is kind of moving to a little bit different talk of where I think we've failed doing this within medicine and how I hope all of us can act as physicians in the future. So this quote at the top was said by Jesus to the people in his hometown of Nazareth. He was addressing concerns that the people at his time had of, if you are really the Son of God, why don't you show us that you can heal yourself? Which I think is a good question to ask. Most of us in life want proof before we trust others or ourselves with our time or money or whatever it is. We want to see that they embody the skill or habit that they're prescribing. So another way to say what Jesus said is, doctor, cast out your own demons before you come here and tell us how to live a better life. So when we care for patients, in my opinion, and I think in the opinion of most doctors, we're looked at and expected to be experts in healthcare. But somewhere along the line in Western medicine, our specialties became so compartmentalized that we kind of lost this idea of forest within the trees. In the same way that we've compartmentalized our society, this kind of weakens us, I think, in a little bit, because we become so much robotic in what we are able to prescribe or talk about, and we get this kind of uncaring, disjointed, for-profit medical system. Martin Luther King had this quote at the bottom over 50 years ago that said, our scientific power outran our spiritual power, and we have guided missiles and misguided men. And that's a great thing as far as an analogy to Western medicine, because we fell into this symptom-based care where a patient's going to come into us with a specific problem, and we're going to hone in on it, and we're going to try to give them an immediate solution without ever looking deeper underneath the surface to see what happened. So my example would be if someone goes into the hospital or to an orthopedic surgery center or clinic, they'll say, I've got knee pain. They're going to go through a couple of range of motion tests, but they'll almost always get a knee x-ray ordered. They'll get an MRI. Once that comes back and nothing's really helping with physical therapy, they'll end up scoping that knee, and then down the line, they'll end up getting a knee replacement. But I don't know if anyone ever stops along the line to ask them what was the cause of that knee in the first place. You guys have pre-opted a bunch of people. I always hear from it that, what happened to your knee? Well, it's my genetics, or, well, I wore out my knee. Our bodies are super amazing organisms that perform billions of cellular processes every day. they don't just wear out, and it's not always genetics. We are designed to live long, healthy, vibrant lives, but we have lost touch with our ability to analyze ourselves and to say, where can we optimize what we're doing on a daily basis, not just to be pain-free, but to live a super healthy, fulfilling life. And ancient physicians understood this pretty much from the inception of medicine, this idea to integrate the design of the human body. Hippocrates had this great quote on here that says, before you heal somebody, ask them if they're willing to give up the things that make them sick. Now, with anesthesia and a pre-op, I very rarely ask that, but if you've got someone coming in for multiple EGDs because they've got chronic acid reflux and Barrett's esophagus, very rarely does anyone go through a nutrition profile with them and ask them, are you sticking to these certain dietary guidelines to try to cut down on the inflammation you're causing in your body? Your body's literally screaming at you saying, don't eat the food you're eating, or get more sleep, or calm down on some of these external stressors, because it is happening so much that I've lost tone of a sphincter and I'm letting acid shoot up in my esophagus. It's crazy, but people don't look at it that way. They look at it as, well, it's just bad genetics or bad luck or whatever it may be, and go on about their life. If you go back to look at the Hippocratic Oath, one of the things that it says, if you take a modern adaptation of it, is that I will prevent disease wherever I can, because prevention is preferable to cure. And so what is this prevention? I talked about this actually in my grand rounds when I was a resident, but there are these 4 pillars of movement, and Hippocrates talks about very similar things thousands of years ago, but it comes down to adequate movement, nutrition, sleep, and mindfulness. So thinking positive thoughts. And if we can't figure out how to do this for ourselves, there's no way that our patients are going to do it. So as doctors and as just humans that are alive, we really need to make health a #1 priority in our life. Because if we can model these prescriptions of movement, nutrition, sleep, and stress management, we can truly walk the walk for our communities as well. The first thing with figuring out what your dream is we got to figure out health incongruences from the way that we say that people should live and how we are actually living. Because the definition of insanity is continuing the same patterns and addictions over and over again, hoping that we're going to have a better outcome. It's the same thing as when you see someone come in with a glucose of 350 and their A1C is 11, who says, I check my blood sugar sometimes, I wish it would go down, and they're getting their foot whacked off. Thinking about it, but actually not putting in the work to try to fix it is never going to help. And so Albert Einstein had this quote about, we can't solve our problems with the same thinking that we used when we created them. So we're going to have to figure out, how do we change this idea of claiming that we want to live better lives, but then continuing to fail at materializing it. So we go back again, I'm going to say this over and over. So we've got to figure out what our dream is. And once we figure that out, then we look at these below factors to say, what is derailing our process, or our progress rather, to live out our full dream? And that's this idea of transmuting your fears into confidence. So when I think about this, I say these are about the 5 most common factors or stumbling blocks you're going to come along or around to whenever you're trying to figure out and realize your dream. So looking at time. How much time are you going to need to accomplish whatever your dream is? And where can you find that in your current daily schedule? As a resident, you all are super busy. And as an attending, I'm super busy. And unfortunately, just as an adult or as a human, we're all going to be super busy all the time, no matter what stage of life we're in. We all have the same 24 hours in a day, but we can prioritize the things that are truly important to us. And once you figure out this driving goal, other non-essential things are going to start falling away, because as you're pursuing greatness in your own life, you're going to realize they're not serving you. Going back to the idea of selling my house, I'm trading the thing that I love for something that I love more. So what I loved more was financial freedom and being able to not necessarily be stuck doing one thing with my family because I have to pay a mortgage, and to find a place that more suits us size-wise. Moving on from that one, going into energy. So you can create as much time as you want in the world, but if you don't have the energy to fuel your dream, it's never going to happen. So the example I give is, if you want to run a marathon, but you can barely have enough energy to get from home to work and then to back home, you're never going to find this additional energy to start training to run. And so one of the concepts that's important to remember is it's going to take a little bit of energy to gain more energy. It's the same way that our digestive system works when we eat food. So it takes energy to break down the food that you eat, to absorb it, to shuttle it all around your body and get those nutrients in. But the goal is that you're going to end that process with a net surplus of energy after you eat. The same strategy can work on the macrocosm of our lives. We just have to go back to those 4 pillars of movement. We've got to figure out, how can we move better, eat better, sleep better, and manage our stress better to gain that energy on the front end, and use it to catapult and grow it and make it exponentially larger as we start pursuing our goal. One thing I will warn you about at this point, which I was super addicted to caffeine and coffee all through residency and up until about 6 to 12 months ago, is if you try to cheat this system with stimulants and coffee, all you're going to do is you're burning your adrenals out, and you're going to lead yourself down the pathway to illness, injury, eventually disease, and probably death if you don't get it under control. So there's no shortcut to this. You just have to put the work in just like everybody else does. The third category is going to be willingness. Are you really willing to follow the dream that you're stating to yourself, or are you following someone else's path? Do you really want to have a fancy car? Do you really want to have six-pack abs? Do you want to have the 2.2 kids and the nice household in the suburbs? If you find yourself, once you've figured out what your dream is, lacking this internal desire and willingness to accomplish it, two things have probably happened. Either one, your stated dream is not an honest reflection of what you want. There's a biohacker, I don't know if you guys have come across, named Tim Ferriss, but basically he takes the 1 to 10 scale and says you should rank every decision you're making on that by already taking out the number 7. Because number 7 is a pretty big cop-out. It can be something that's kind of inspiring to you, kind of good, but it's not super exciting and it's not super terrible. Most everything would fall around that. So if you eliminate a 7 out of any decision you're making, and if you rate something of, do I want to pick up this extra paper assignment that someone wants you to write on in residency, or if it's, do I want to go spend my weekend traveling somewhere versus staying at home and resting, if it falls on that 1 to 6 slide, don't do it, because it's not really serving you in your overall goal of living the best life you can. If it's on 8, 9, or 10, it's probably pretty important to you, and you should at least try to do it. So that way you can see, were you correct in your thinking that this was going to serve you in a better way? And that's how you live a intentional life and grow and learn from previous things that you've done. So that's one thing that can happen. The other thing that may cause a lack of willingness is that you've just depleted yourself so much of your own life energy that you can't even conceptualize what a better life would look like. So either way, while you're figuring out what your true dream is, go back to visualizing and optimizing your own health. If you're that tired and down, which I've been that way too at times, and all of us will go through those periods, look at what you're doing. Are you eating well? Are you moving well? If you're on a super crappy rotation, like, I don't know, when I was a CA2 going through SICU, that was terrible. I could hardly sleep. But I at least tried to make sure that I was bringing healthy meals while I was there. You take control of the things that you can control and weather that storm, and it'll eventually ride itself out, and you're going to feel better and live better and have more clarity and thought to what you want in life. Going on to finances, how much money do you need to accomplish whatever your specific dream is? As physicians, we have the opportunity, and I highlight the word opportunity, to be financially wealthy. If we seek short-term comfort and keeping up with the Joneses and kind of just haphazardly spending our money on things that are kind of interesting to us but not really serving us, you're going to fall prey to the same societal pressures that anyone else can, and you're going to have a lot of debt and feel very much trapped in the job or situation that you're currently in. Use the blessing of the increased financial wealth that you guys are going to have very soon to hone in on, where can I allocate this hard-earned money to live my best life? And that kind of leads us into the last one, is equipment availability. So what do you need to have to fully live out your dream? So going away from my idea of health, which you can talk about, do you need gym shoes, a gym membership, a gym at your house, all those things. Say your passion is cooking. What kind of dream kitchen would you need to be able to bake or make whatever the foods are that you love preparing? What kind of other cutlery, refrigeration, utensils, and other food stuff that I really have no idea about, what would you need to do that? That's going to help you in 2 ways. One, it keeps you very focused and keeps you from getting derailed on your dream. And it makes future financial decisions more meaningful when you make them. You can get super excited when you buy whatever fancy, mixing bowl that you get, because to you, that is helping you express yourself in the highest way that you can. And so that's kind of reaching the end of this. I wanted to say again that being a resident is hard. You guys know that. Going through medical school is hard. All of life can be hard, but the big deal is to say you can take control over any situation that you're in. It just takes time and practice. So while I hope that this was a little bit inspiring and not too overwhelming, it's good to have mentors when you're learning new skills, just the same way as you guys have awesome attendings there at University of Cincinnati to teach you things. And I hope to kind of branch out a little bit from this and start teaching physicians and advanced level practitioners how to do these things in their own life. But just wrapping up, taking a holistic approach to your health from all the different pillars, not just physically, but mentally, emotionally, spiritually, financially, and then just in your societal groups, you can create a better future for yourselves and then for medicine as well. So this is my contact information. We have a YouTube channel that we're just getting started. There's going to be more stuff popping up over there in the next month or two. That is my wife's contact stuff if anyone's interested in looking at her stuff on Instagram or her website. And that's all I have for you. So if you guys have any specific questions about intentional living or health and wellness practices in general, I'm happy to answer that. And then also, as an aside, I don't know how many people you guys talk to that are in private practice. I'm also happy to answer questions that you all have about picking a job and what it's like outside of the medical supervision or a medical direction model. But I also know it's late in the day, and you guys feel free to sign off as well. Thank you.
Thanks, Will.
Thank you.
Yeah, no worries, guys. I hope you have a good rest of your day.
Thanks so much, Will.
Yeah, man. Take it easy, Carl. I'll catch up with you soon.
Carl, that is like you in 3 years. To a T.
We maybe have similar interests and goals.
It feels dirty eating insomnia cookies by the
I'm totally gonna get like Saber later.
James, there's nothing wrong with that.
one other say.
Yeah, it's what makes me happy, and
Yeah. Well, I think you would say, and what I would say too is like it's not just about like only eating like clean or healthy all the time, but it's being like cognizant of like, is this what I want right now?
Yeah.
And is this a pattern?
It's
and
a
like
balance thing.
Exactly.
I mean, my personal growth is a little different than other.
Well, and
I grow this way.
dude, you talk all the time about how you're like working out at home and like you're committed to that. And so like you're active in your health. And so if occasionally you're like, yeah, I freaking want Saber because that's what I really want.
Or not so occasionally, you know?
It's fine though.